Good afternoon. Today we'll talk about mixed degenerations. Mixed degeneration is a pathological process which affects stroma and parenchyma. This kind of degeneration includes the metabolism disturbances of nucleoproteins, lipoproteins, mineral substances, and chromoproteins. Pigments are colored substances present in most living beings, including humans. There are two broad categories of pigments. It's endogenous pigments and exogenous pigments. Endogenous pigments are either normal constituents of cell or accumulate under special circumstances like melanin, ochronosis, hemoprotein-derived pigments, and lipofuscin. Exogenous pigments are those which are introduced into the body from outside, such as by inhalation, ingestion, or inoculation. Endogenous pigments. According to the pigment structure, endogenous pigments are classified into proteinogenic or tyrosinogenic pigments, hemoprotein-derived pigments, and lipidogenic pigments. Melanin is a proteinogenic brown-black pigment normally present in the hair, skin, choroid in the eye, meninges, and adrenal medulla. It is synthesized in the melanocytes and dendritic cells, both of which are present in the basal cells of the epidermis and is stored in form of cytoplasmic granules in the phagocytic cells called the melanophorocyte, present in the underlying dermis. Melanocytes possess the enzyme tyrosinase necessary for synthesis of melanin from tyrosine. However, sometimes the tyrosinase is present, but it is not active and hence no melanin pigment is visible. Various disorders of melanin pigmentation cause generalized and localized hyperpigmentation and hypopigmentation. When we talk about generalized hyperpigmentation, there's usually examples of Addison disease, as we see in the left picture, and chloasma, which is observed during pregnancy in the hyperpigmentation of skin and face, nipples, genitalia, and occurs under the influence of estrogen, like it's seen in the right picture. Focal hyperpigmentation is seen in neurofibromatosis and Albright syndrome, the left picture. Bates-Yeager syndrome is characterized by focal perioral pigmentation. Melanosis Coli, it is seen in the large microphotograph, is a pigmentation of the mucosa of the colon. Melanocytic tumors, both benign, such as pigmented nevus, and malignant, such as melanoma, are associated with increased melanogenesis. Generalized hypopigmentation is an albinism with an extreme degree of generalized hypopigmentation in which tyrosinase activity of the melanocytes is genetically defective and no melanin is formed. Albinos have blonde hair, poor vision, and severe photophobia. They are highly sensitive to sunlight. Chronic sun exposure may lead to precancerous lesions and squamous and basal cell cancers in the skin in such individuals. Localized hypopigmentation, it's leukoderma, vitiligo, and acquired focal hypopigmentation. Vitiligo is much more common, and it's a local hypopigmentation of the skin. It may have familial tendency. Hemoprotein-derived pigments. Hemoproteins are the most important endogenous pigments derived from hemoglobin, cytochromes, and their breakdown products. For an understanding of disorders of hemoproteins, it is essential to have knowledge of normal iron metabolism and its transport. In disordered iron metabolism and transport, hemoprotein-derived pigments accumulate in the body. These pigments are hemosiderin, hematin, bilirubin, and porphyrins. Hemoprotein-derived pigments include normal, like ferritin, hemosiderin, and bilirubin, and pathological, like hematoidin, hematin, and porphyrin. Ferritin is iron complex and to apoferritin and can be identified by electron microscopy. It is located in liver, spleen, bone marrow, and lymph nodes. There are two forms of ferritin, inactive and active, formed due to lack of oxygen, characterized by vasoparalytic and hypotensive actions. Active ferritin is adrenaline antagonist. The pathological condition characterized by increasing of level of ferritin in blood and tissues is hemocytorosis. Hemosiderin, which is formed by aggregates of ferritin and is identified by light microscopy, is golden yellow to brown granular pigment, especially within the mononuclear phagocytes in the bone marrow, spleen, and liver, where breakdown of red cells takes place. Hemosiderin is ferric iron that can be demonstrated by Prussian blue reaction. Excessive storage of hemosiderin occurs in situations where there is increased breakdown of red cells, or systemic overload of iron due to primary idiopathic hereditary hemochromatosis and secondary acquired causes such as thalassemia, sideroblastic anemia, alcoholic cirrhosis, multiple blood transfusions, and so on. Accordingly, the effects of hemosiderin excess are as under: local hemosiderosis, which develops whenever there is hemorrhage in the tissues. With lysis of red cells, hemoglobin is liberated, which is taken by the macrophages, where it is degraded and stored as hemosiderin. The change in colors of bruise or a black eye are caused by the pigments like biliverdin and bilirubin, which are formed during transformation of hemoglobin into hemosiderin. In the microphotograph, we see a lot of hemosiderophages in the center of the picture. Another example of local hemosiderosis is brown induration of the lungs as a result of small hemorrhages, as occur in mitral stenosis and left ventricular failure. Microscopy reveals the presence of heart failure cells, which are hemosiderin-laden alveolar macrophages. Generalized hemosiderosis. The systemic overload with iron may result in generalized hemosiderosis. There can be two types of patterns: parenchymatose deposition of hemosiderin, which occurs in parenchymal cells of liver, pancreas, kidney, and the heart. The causes for parenchymatose hemosiderosis include excessive intestinal absorption of iron, like in hemochromatosis, increased erythropoietic activity, like in hemolytic anemia, excessive intake of dietary iron. When we talk about reticuloendothelial deposition of hemosiderin, it occurs usually in following repeated blood transfusions or after parenteral iron therapy. Idiopathic hemochromatosis is an autosomal dominant disease characterized by excessive absorption of iron. It is associated with triad of pigmentary liver cirrhosis, pancreatic damage resulting in diabetes mellitus, and skin pigmentation. On the basis of the last two features, the disease has to come to be termed as bronze diabetes. Bilirubin. It's normal hemoglobin-derived non-iron containing pigment which presents in the bile. Bilirubin is formed in the cells of reticular endothelial system in erythrocytes destruction and enters the blood. This is non-conjugated or indirect bilirubin. It enters the hepatocytes where it is associated with glucuronic acid, and then it becomes conjugated bilirubin. Then it enters the small intestine, where some of it enter the blood, and the last portion colors the stool and urine, which we know as stercobilin and urobilin. Normal levels of bilirubin in blood is less than 1 mg per deciliter. Excess of bilirubin causes an important clinical condition called jaundice. Briefly, jaundice appears to be one of the following three ways. It's prehepatic or hemolytic when there is excessive destruction of red cells, posthepatic or obstructive, which results from obstruction or to the outflow of conjugated bilirubin, and hepatocellular or hepatic, that results from failure of hepatocytes to conjugate bilirubin and inability of bilirubin to pass from the liver to intestine. Excessive accumulation of bilirubin pigment can be seen in different tissues and fluids of the body, especially in the hepatocytes, Kupffer cells, and biosinusoids. Skin and sclera become distinctly yellow, and infants' rates of unconjugated bilirubin may produce toxic brain injury. Hematin, the hematoprotein-derived brown-black pigment containing hem iron in ferric form. It differs from hemosiderin because it cannot be stained by Prussian blue reaction. Hematin pigment is seen most commonly in chronic malaria, as in mismatched blood transfusions. There are three types of hematin: muriatic hematin, which is formed in gastric erosions and ulcers as a result of interaction between hemoglobin and enzymes with chloric acid of gastric juice; hemomelanin, which is a brown pigment produced by malarian parasites from hemoglobin. It is taken up by monocytes in the blood and subsequently deposited in the liver and spleen. And formalin pigment, which looks like dark brown grains. It can be found in the tissues fixed with acid formalin, with pH below 6. Porphyrins. are tetrapyroles, which exist in three forms in nature combined with different metals: Hem containing iron, chlorophyll, which contains magnesium, and cobalamin, which contains cobalt. Porphyria result from genetic deficiency of one of the enzymes required for synthesis of Hem. So there is excessive production of porphyrins. Often the genetic deficiency is precipitated by intake of some drugs. Porphyrias are broadly of two types: erythropoietic and hepatic. Erythropoietic porphyria have defective synthesis in Hem in the erythrocytes. These can be further of two subtypes. It's congenital type, in which the urine is red due to the presence of uroporphyrin 1 and coproporphyrin 1. The skin in these infants is highly photosensitive. Bones and skin show red-brown discoloration. Erythropoietic protoporphyria, in which there is excess of protoporphyrin but no excess of porphyrin in the urine. Then the big group of hepatic porphyrias. These are more common and have a defect in synthesis of Hem in the liver. Its further subtypes include the following: acute intermittent porphyria, which is characterized by acute episodes of three patterns: abdominal, neurological, and psychotic. These patients do not have photosensitivity. Variegate porphyria is common in whites in South Africa. Photosensitivity occurs, and there are acute attacks of abdominal pain and some neurological manifestations. Then, hereditary coproporphyria is quite rare, and Porphyria cutanea tarda is one of the most common of all porphyrias. Porphyrins collect in the liver, and small quantity is excreted in the urine. Skin lesions are similar to those of variegate porphyria. Most of the patients have associated hemocytorosis with cirrhosis, which may eventually develop into hepatocellular carcinoma. Lipidogenic pigments include lipofuscin pigment of vitamin E insufficiency, ceroid, and lipochrome. Lipofuscin is yellowish-brown intracellular lipid pigment. The pigment is often found in atrophic cells, usually in myocardial fibers, hepatocytes, cells of testes, and neurons. The pigment accumulates in the central part of the cells around the nucleus. In the heart muscle, the change is associated with wasting of the muscle cells and is commonly referred to as brown atrophy. Deposition of lipofuscin in neurons is seen in senile dementia. Lipofuscin represents the collection of indigestible material in the lysosomes after autophagy, and therefore an example of residual bodies. The pigment can be stained by fat stains, but differs from other lipids by being fluorescent and acid-fast. By electron microscopy, lipofuscin appears as intralysosomal electron-dense granules in perinuclear location. These granules are composed of lipid-protein complexes. Inhaled pigments. It's a part of big group of exogenous pigments. The lungs of most individuals, especially of those living in urban areas, due to the atmospheric pollutants and smokers, show a large number of inhaled pigmented material. The most commonly inhaled substances are carbon and coal dust. Others are silica or stone dust, iron or iron oxide, asbestos, and various other organic substances. These substances may produce occupational lung diseases called pneumoconiosis. The pigment particles after inhalation are taken up by alveolar macrophages. Some of the pigment-laden macrophages are coughed out via bronchi, while some settle in the interstitial tissue of the lung and in respiratory bronchioles and pass intralymphatic to be deposited in the hilar lymph nodes. Anthracosis, also known as deposition of carbon particles, is seen in almost every adult lung and generally provokes no reaction to tissue injury. However, extensive deposition of particular material over many years in coal miners, pneumoconiosis, silicosis, asbestosis, provoke low-grade inflammation, fibrosis, and impaired respiratory function. Ingested pigments. Chronic ingestion of certain metals may produce pigmentation as well. The examples are as under: argyria, which is a chronic ingestion of silver compounds and result in brownish pigmentation of the skin, bowel, and kidney. chronic lead poisoning, which may produce the characteristic blue lines on teeth and gum line. Melanosis Coli results from prolonged ingestion of certain cathartics. And carotenemia. It's a yellowish red coloration in the skin caused by excessive ingestion of carrots, which contain carotene. Injected pigments or tattooing. It's pigments like India ink, cinnabar, and carbon, which are introduced in the dermis in the process of tattooing, where the pigment is taken up by macrophages and lies permanently in the connective tissue. The examples of ingested pigments are prolonged use of ointment containing mercury, dirt left accidentally in the wound, and tattooing by pricking the skin with dyes. Okay, let's talk about pathological calcification. It's a deposition of calcium salts in tissues other than osteoid and or enamel, is also known as heterotopic calcification. Three distinct types of pathological calcification are recognized. It's dystrophic calcification, which is characterized by deposition of calcium salts in dead or degenerated tissues with normal calcium metabolism and normal serum calcium levels, which is very important. Metastatic calcification, on the other hand, occurs in apparently normal tissues and is associated with deranged calcium metabolism and hypercalcemia, and metabolic calcification may cause of its development as instability of buffer systems of the blood and tissue liquid. Histologically, in routine aging hematoxylin and eosin stains, calcium salts appear as deeply basophilic, irregular, and granular clumps. Etiology and pathogenesis of the three types of pathological classification are basically the same, but they're absolutely different, but morphologically, all the deposits are absolutely the same. Dystrophic calcification may occur in dead tissue or in degenerated tissue. When we talk about dead tissue, it's usually due to caseous necrosis in tuberculosis, liquefaction necrosis in chronic abscesses, fat necrosis, infarcts, thrombi, usually in veins when they produce phlebodates. Hematomas in the vicinity of bones may undergo dystrophic calcification. Dead parasites like hydatid cyst, schistosoma eggs, and cystic sarcosis. Calcification in breast cancer, which can be detected by mammography, and congenital toxoplasmosis involving the CNS. When we talk about degenerated tissues, it's usually seen in old scars, which may undergo hyaline degeneration and subsequent calcification. In atheromas of the aorta and coronaries. Mockenberg sclerosis, it's a classical example of calcification in tunica media of arteries. Stroma of thumb tumors. Old cyst in skin, which is known as calcinosis cutis. And senile degenerative changes may be accompanied by dystrophic calcification, such as in costal cartilages, tracheal bronchial cartilages, and so on. This is a classical example of dystrophic calcinosis when we see very dark staining material, which is actually calcium in an artery. Metastatic calcification occurs in normal tissues due to hypercalcemia. It can be due to excessive mobilization of calcium from the bone and excessive absorption of calcium from the gut. The causes for excessive mobilization of calcium from the bone may be hyperparathyroidism, which may be the primary, such as due to parathyroid adenoma, or secondary, when we talk about parathyroid hyperplasia, chronic renal failure, and so on. Bony destructive lesions such as multiple myeloma, metastatic carcinoma, and prolonged immobilization of a patient results in diffuse atrophy to the bones and hypercalcemia. Excessive absorption of calcium from the GI tract. The examples are hypervitaminosis D, milk alkali syndrome, which caused by excessive oral intake of calcium in form of milk and other sources. Hypercalcemia of infancy is another condition in which metastatic calcification may occur. Metastatic calcification may occur in normal tissue of the body, but affects the following organs more commonly. Kidneys, especially at the basement membrane of tubular epithelium in the tubular lamina, causing nephrocalcinosis. And lungs, especially in alveolar walls, and stomach, on the acid-secreting fondal glands, in blood vessels, especially in the internal elastic lamina, and cornea, which is another site affected by metastatic calcification. The pathogenesis of metastatic calcification at the above-mentioned sites is based on hypothesis that these sites have relatively high pH, which favors the precipitation of the calcium. And finally, metabolic calcification. The mechanism of metabolic calcification development is not clearly understood. The principal value is significance to instability of the organism buffer system. Owing to this instability, salts of calcium are not kept in blood and interstitial fluid. Hereditary sensitivity of tissues to calcium has a significant role too. And finally, disturbances of nucleoproteins metabolism. They are characterized by excessive formation of uric acid and precipitation of its cells in the tissues. This process is observed at gout, urolithiasis, and uric acid infarctions of kidney. The most common one between those, it's a gout, which is characterized by periodic precipitation of sodium salt of uric acid in joints, accompanied by painful attack. An increase of uric salts content in blood, which is known as hyperuricemia, and urine, hyperuricuria, is found in patients. The salts are usually accumulated in synovia and cartilages of foot and small joints of hands, talocrutal and knee joints, in tendons and articular bags, in the cartilage of auricles. There is necrotizing of tissue in which salts precipitate in the form of crystals or amorphous substances. An inflammatory reaction with appearance of giant cells develops around salt depositions and necrotic foci. The development of gout is mainly caused by congenital disturbances of metabolism, and thus the role of dietary habits and overuse of animal proteins is great. As you can see, we see accumulation of uric acid crystals and very specific productive inflammatory reaction at the periphery. Thank you very much for your attention.